Good morning. This is a very interesting topic for me, and one of the primary reasons that I've since delved into natural medicine with our line of healing supplements, the Well Theory, and then also the Healing Soul, which is a shoe I designed to treat foot pain. But what really got me interested to the fundamental causes of many of our orthopedic conditions is what I've seen on a day-to-day basis with my diabetic patients. So we treat a tremendous number of diabetic foot wounds and things like diabetic toenail problems, diabetic foot contractures, peripheral neuropathy, peripheral arterial disease, tight and cramped up connective tissues. And as we've treated these surgically and non-surgically in my clinic, over the years, I've delved into the basic science and the fundamental research behind what is going on with these ulcers and wounds. And I'm going to talk to you about that today. So this is going to be a brief overview of multiple topics that pertain to diabetics and diabetic foot wounds, and then how we, particularly my clinic, where we're experts in this, treat diabetic foot wounds. So we're one of the only places that I'm aware of that has the ability to do both peripheral nerve surgery, orthoplastics procedures, any sort of hardware surgery that's necessary, also any non-operative wound care, such as applying advanced wound care products, wound debridements. And then we are even able to do things like IV therapy with ALA, which is alpha lipoic acid, and other substances that promote and enhance wound healing. So we're able to provide multiple different ways to offload and treat diabetic foot wounds. And this even includes things like physical therapy and an infrared sauna bath, like a full body infrared treatment. So we have all of these capabilities, and I'm just going to kind of share with you why we have all of that and how it helps and what is a diabetic wound and so on and so forth. So if you have diabetes, prediabetes, metabolic syndrome, or know somebody in your family that does, this is a talk for you. Okay, my name is Dr. Meredith Warner, and I'm an orthopedic surgeon in Baton Rouge. Now, I treat all things orthopedics, and we have a wellness clinic, and we do a lot of things with weight loss and diabetes. But right now, my real love for surgery is trying to do what we call limb salvage and pain relief. So I do a lot of peripheral nerve surgeries, a lot of orthoplastics for diabetic foot wounds, different tendon rebalancing, different types of procedures really to enhance function and improve people's lives, also to cure and treat ulcers. And so we're going to talk about that today. All right, this is the physical therapy clinic in my clinic. So I walk from one hall right here. They're about 6 feet away from me when I'm seeing patients, and I can see my patients having physical therapy, pre-surgical, post-surgical, trying to avoid surgery, which I will tell you that my team of physical therapists are so good that they've actually reduced my surgical schedule. So we're able to treat things like rotator cuffs, meniscal tears, arthritis, you name it, orthopedically, and there are ways to treat it non-surgically, and that's our primary goal. But I am going to tell you about the surgeries that are potentially helpful for diabetic foot wounds that aren't healing. That's going to be the focus of this this talk. So diabetes and wounds, we're going to talk about what actually is considered a quote unquote diabetic foot. What is a wound or an ulcer? What is neuropathy? We're going to delve briefly into this entity called Charcot arthropathy, which is a subset of the diabetic foot that is quite damaging and deforming. And then we're going to talk about how you can treat the wounds, how you can prevent the wounds, what medical and surgical options may or may not help you. And then just remember, all of this is education and entertainment. I certainly can't act as anybody's treating physician through an online webinar, but anybody is welcome to come see me in my clinic if you have these problems. And I would encourage you to do so because we are experts in diabetic foot wounds. And we are one of the only places in the Southeast that is able to offer everything from non-surgical to surgical care of diabetic foot wounds. Okay. So think of your orthopedic surgeon as someone able to provide advanced care for diabetic foot ulcers, okay? We can do wound care, which is your normal debridement that you're probably familiar with. But we can also do enhanced total surgical debridement, complete with different surgical washes and applications that occur in the sterile setting of the OR. And then I am particularly able to do orthoplastics procedures where we can actually transfer soft tissues to cover wounds as opposed to just going to a prolonged, year after year of wound care. In addition to things like rotation flaps, pedicle flaps, skin grafts, etc., we're also able to do nerve decompressions and nerve repairs and nerve transfer surgeries. And this helps to reduce the symptoms and complications that are associated with the neuropathy, which is one of the fundamental causes of a diabetic foot ulcer. So all of this needs to be thought about, and it's hopefully whoever's taking care of your foot wounds or your family members' foot wounds has all of these capabilities under one roof like we do. But if not, please come see us. So I'm going to talk briefly about nerve decompressions and repairs. This is a way to enhance the symptom management of diabetic peripheral neuropathy. Now, peripheral neuropathy is essentially uncurable, but in some cases, neuropathy exists with a coincident or a simultaneous compression or conduction block neuropathy on top of it, which makes it way worse symptomatically and also makes it very, very difficult for the body to heal any nerves if it's going to have a chance to do so. So what we do, and we actually have the ability to do the electrical testing too in-house, we will localize the site of the entrapment or the conduction block of the main nerves. And then if we can't release it non-surgically with like the ALA infusion therapy or with physical therapy and things like that, then we can actually do nerve release surgeries. And these images, I forgot to tell you in the beginning, there are going to be some graphic medical pictures. So if you can't handle that, just keep that in mind. These images show you some nerve release surgeries that I do commonly. And when you release these nerves and take pressure off of the main trunks of the nerves and important branches, you can actually improve symptoms and prevent ulcerations and actually improve neuropathy in a way. In addition, I've even done things for people where we denervate or do a partial denervation of a portion of a painful foot. And in that way, we can reduce symptoms of pain without having somebody to go through a huge reconstructive procedure. And they maintain the normal function of their foot and have no downtime. So there's a lot of tricks with nerves that can help people with diabetes, neuropathy, neuropathic pain, Charcot arthropathy, diabetic foot ulcers. So just keep that in the back of your mind. So our care team, and I want you to think about orthopedic surgery as the ultimate foot doctor. Our care team, I have a nurse practitioner, advanced practice nurse who's got extensive education and experience with diabetes and weight loss and management of those things, and also wound care experience. In addition, obviously, I have extensive wound care experience. Combine that with my surgical expertise, and then combine that with our physical therapist, and then the adjunctive care that we can do. For instance, we partner with Thrive IV to offer ALA IV therapy for diabetic peripheral neuropathy and diabetic foot wounds and other nerve-based pain. And then we've got the infrared sauna, like I told you about, and we offer a bunch of different other modalities, and we also do the electrodiagnostic testing. So what you want, if you're going to have really good care of a diabetic foot ulcer, is sort of the ability to do all of these things. You don't want to have to go from clinic to clinic to clinic and then get things lost in translation or lost in cyberspace, as we're all aware happens all the time in medicine. So what is the diabetic foot? Well, the World Health Organization in 1995 defined it as such. And I quote, "The diabetic foot may be defined as a group of syndromes in which neuropathy, ischemia, and infection lead to tissue breakdown, resulting in morbidity and possible amputation." So what you need to remember is there's neuropathy, which we just talked about briefly, ischemia, which is a lack of oxygenated blood flow to the foot, and then infection. So obviously all three of these things, particularly if they happen together, are going to result in abnormal tissues that can't heal properly. Then you get the breakdown, and then ultimately it leads to ulceration, and ulcerations more often than not can lead to amputations. Now, my goal in my clinic is limb salvage. No matter what, we try to avoid amputations if at all humanly possible. So there is an initial lesion that should be looked for, and you should be aware of this. That is what leads to ulceration and amputation down the road. So a foot like this with just that little bit of dry cracked skin, the toes curl down, they become contracted, you lose a little bit of muscle mass in the foot. All of these are signs of early onset of diabetic foot ulcers that could lead down the road to badness, which we want to prevent. So if you have a non-healing skin ulcer, and that can be even something as simple as just an area of what we call callus or hyperkeratosis, that's like one of the first stages. And this is usually coincident with an area of higher regional pressure, either from a foot deformity or a tight fitting shoe or something like that. And then if that's linked to the neuropathy, ischemia, and infection, that's when disaster happens. Just so you know, and so you don't beat yourself up if you're undergoing care for an ulcer or you have a family member that is, sadly, with standard treatment modalities today in America, about 80% of ulcers will recur. And this is likely due to either poor treatment choices, poor combinations of treatment choices, and or likely like a poor response to treatment from patient factors. So all of this needs to be considered. And my goal in my clinic is to reduce that recurrence rate, hopefully to zero, and then to compress the time it takes to get the ulcer to heal. So what is the scope of this problem? How big of a problem is this really in the world? Well, in the United States in 2018, which gosh, that's 6 years now, 34.2 million had the official diagnosis of diabetes. Obviously, we know that's more now. 88 million were pre-diabetic. And believe it or not, peripheral neuropathy is diagnosed more often in the pre-diabetic population than the diabetic population. So even if you're pre-diabetic, do not think you're out of the woods with this. Pre-diabetes just means that your pancreas hasn't given up completely. It doesn't mean that you don't have all of the hallmarks of insulin resistance. And speaking of which, about 175 million of our population, or about 50% now, we think are insulin resistant. And that's just from having too much added sugar in your diet. And then if you have diabetes, you have a 4% chance every year of getting a diabetic foot ulcer, and then a 34% chance of getting one in your lifetime. So there's a huge odds. So obviously, if you can avoid being insulin resistant, that's ideal. If you're pre-diabetic, if you could reverse it back to insulin resistance and then back to normal insulin levels, that's ideal. If you're diabetic, you just need to manage your blood glucose and keep it controlled as much as possible. And then, of course, this is expensive, not just for you, not just for the hospital systems, but for society at large and for globally. So $9 to $13 billion each and every year, we think, is spent directly on diabetics with diabetic foot ulcers. If you are a diabetic and you have a foot ulcer, you cost 5.4 times more than a diabetic without a foot ulcer. And then these lead to amputations. And then what's worse about that, or what's the worst thing that happens with an amputation, is there's a 50% mortality rate, meaning when you get diagnosed with a diabetic foot ulcer, you have a 1 in 2 chance of dying within 3 years. So the mortality rate goes up by 50% within 3 years after an amputation for a diabetic foot ulcer. Sorry, it's after you have an amputation, not just diagnosed with an ulcer. And this graph sort of shows that after 3 years, the morbidity rate goes way up. And then sadly, nowadays, more and more young people are needing amputations for ulcers, and that's been growing since 2010 or so. Similar to, you've probably heard news stories about the rates of cancer diagnoses in young people are going up. Same thing with diabetes. And of course, we know that the fundamental source of all of these problems is chronic low-grade inflammation and oxidative stress, along with advanced glycation end products, leads to all of these so-called lifestyle diseases, to include cancer and insulin resistance. So it's sort of all linked. So if we can get all of this under control with the diabetes, I think you'll see those other rates of things like cancer go down as well. So it's estimated that if you have a diabetic foot ulcer, you cost about $20,000 a year to treat, and I'm sure those are low numbers. And then if you get an amputation, you cost about $50,000 a year to treat. And now, of the global population, 10 to 12% have diabetes type 2. I put these images here to show you. This is from a conference in Abu Dhabi, and this is a new medical center that the Imperial College of London built in Abu Dhabi. So if this all sounds bad and it sounds, oh, it's so expensive and whatever, but remember, that means it's a big business for people. So wound care is a huge business and makes a lot of people a lot of money. And I don't want you to be a pawn in that game. That's why I'm giving you this information. And just look at this. The orange dots are 1980 number of diabetics per region. And then the red dot is 2014. Again, that's 10 years ago. So what? Oh, all right. Sorry. This map is supposed to show you sort of a heat map with circles indicating the change in the prevalence of diabetes in different regions from 1980 to 2014. And the red dot, which is 2014, is even bigger now because it's 10 years later, right? But the Americas went from 5% of the population to 8.3% in just that short time. The Eastern Mediterranean region went from 6% to almost 14%. Africa went from 3 to 7. Asia went from 4 to 8. So almost everybody's essentially doubled, and it's probably even more now. And why is this happening? Sedentary lifestyles, unhealthy diets, aging populations, urban expansion. So people are getting out of the rural, highly active, more circadian based, eating less, burning more calories lifestyle to the urban, very convenient lifestyle, and then economic growth. So anytime you have an explosion in socioeconomic worth, the diabetes and obesity rates go up. So this is sort of the algorithm that's in the back of our heads when we see a patient with diabetes and a diabetic foot ulcer, or even something as simple as a little dry, cracked skin on the foot, fungus in their toenail, whatever. All of these are canaries in the coal mine, so to speak, okay? We look for things like sensory neuropathies, for motor neuropathies, meaning the muscles are affected too. Peripheral arterial disease, that's decreased blood flow, so there's less oxygen going to the tissue. Autonomic neuropathy, which I'll talk about briefly later in the talk. Things like small muscle wasting or contractures of the connective tissues. This is one of the primary issues with all orthopedic conditions. When the extracellular matrix of a connective tissue, which is sort of the gelatinous fluid that the cells exist in, and things like tendons, fascia, cartilage, bone, etc., when those become disorganized, filled with chronic inflammation and oxidative stress, all kinds of dysfunction and pain happens. So one of the best treatments is to rehabilitate the extracellular membrane. And that's kind of what we try to do with some of our treatment modalities. We talked about the increased foot pressures from deformities and tight-fitting shoes. Anytime you have increased contact pressure, combined with a poor healing response, combined with the inability to feel that increased contact pressure, that's when you're a foot at risk, we say. And this leads, of course, to foot ulcers. One of the reasons it's important to get your diabetic inserts every year and your diabetic shoes is because these are designed to sort of fit a shoe without a seam rubbing any part of the shoe. The toe box of the shoe is usually deeper and wider, and the materials are a little bit more forgiving. And these are all important to protect your foot from abnormal contact pressures. And that's another thing we offer in my clinic is we are able to offer diabetic foot inserts, custom crow boots for Charcot people. Anything that's needed for diabetes, we can produce even on the orthotic side. So again, Meredith talked about the 3 major factors to form a diabetic foot ulcer: neuropathy, peripheral arterial disease, and infection. I'm going to delve into them briefly now each. This top right picture is somebody's heel, and that little spot on the bottom right of that heel is an area where a rotation flap had just started to open up again. So this person got brought back for a surgical debridement, a washout. We placed this substance that's sort of like collagen inside of the wound combined with some antibiotics, and we did a little bit of soft tissue rearrangement like an orthoplastics case and closed it up, and she's doing very well now. The picture on the bottom is showing you an artery. That darker pink area should be open and ready to accept blood flow, but it's filled with cholesterol, filled with plaquing and peripheral arterial disease. So you can see those 2 irregular white areas. That's the only space for the oxygenated blood cells to get through to the tissues. So obviously that person's going to have trouble healing anything. This image is supposed to depict normal nerves on the left and sort of neuropathic nerves on the right. The nerves just become dysfunctional. The insulation of each of your sensory and motor and pain nerves out in the distal parts of your hands and feet, the insulation thins out and becomes damaged. That's called the myelin sheath in medicine, but it's the same thing as insulation in electrical work. So with peripheral neuropathy, you get a loss of normal sensation, or what we call protective sensation. So think about this. If you ever kick your heels up on a coffee table, after a while you have to move, right? Because it starts to hurt. So you shift a little bit, or you switch the other feet and cross it over the other way, so on and so forth. Well, if you have peripheral neuropathy, you never notice that. And what happens is eventually the pressure gets such that you you get this whole area where there's absolutely no blood flow, the tissue's crushed, and you get the early ulcer formation. That is why protective sensation is extremely important, and why peripheral neuropathy should always be addressed in these patients, and in you if you have this. Small fiber neuropathy or small fiber dysfunction, this isn't picked up on any tests except for a skin biopsy. And this is a very common cause of severe neuropathic pain. Loss of pain and temperature perception. You lose the so-called gift of pain. So we all think of pain as something bad, but pain is really protective in a lot of cases. Large fiber dysfunction, which leads to balance problems and your inability to know where you are in space. Motor neuropathy, which leads to like restless leg syndrome, calf cramping, foot cramping, things like that. Muscle pain. Muscle wasting, or you just lose muscle because you lack neural input. And then, of course, the connective tissue contractures from the damaged extracellular membrane we talked about. You'll get different tendons that'll contract up, and then you get these deformities, and you form an ulcer because of that. And I'm going to talk about that briefly too. All of this needs to be thought about and addressed when you're having your diabetic foot wound assessed, evaluated, and managed. So neuropathy is key. So this is normal skin and small fiber neuropathy. When you do these skin biopsies, you actually are looking and counting the number of epidermal nerve endings, and they're diminished. There's less in somebody with small fiber neuropathy, and then this leads to aberrant firing of what are called the C fibers, which is pain, and you get neuropathic pain. So you need to look for nerve problems early and be aware of them and know how to look for them. And then if you identify them, particularly if you identify them early, then you can treat them. You can change nutrition, okay, which is a huge problem and probably the source of all of this. You can offer supplements that help with nerve inflammation, things like alpha lipoic acid, palmitoyl ethanolamide, B-complex vitamins, different IV infusions. You can offer surgery, like we talked about, releasing entrapped nerves, denervating certain areas, doing nerve transfers to enhance nerve function and improvement. You can do physical therapy, okay, to release things like the Achilles tendon, posterior tibial tendon, different contracted tendons to take away deformities and reduce pressures. And then you can incorporate alternative therapies such as acupuncture in some cases, and things like red light therapy where the longer waveforms penetrate the tissue, attached to things called chromophores, which then change behavior of cells. All of these things can be used if you can catch these nerve problems early, and then you can potentially prevent an ulcer from happening. Motor neuropathy is something a lot of people don't think about. I see it all the time. This is when the toes curl up. This is when you can start to see the cavity between the long bones and the foot because you've lost muscle. This is when you start getting the calf cramping and the restless leg syndrome at night. These pictures are showing you cross sections of the MRIs, which we do and we are able to look at. And we can measure foot muscles and actually measure them before and after therapy. We do a lot of therapy to improve balance and improve foot core strength because it's hugely important for diabetics to have a good sense of balance and a strong foot that's a functional foot. We understand that, and I have a crack team of therapists, like I said, that work with this. But motor neuropathy is something that's forgotten about a lot in lieu of the sensory neuropathy that everybody's sort of focused on, or the painful neuropathies. But motor neuropathy plays a huge role in your outcomes in terms of diabetes, diabetic foot ulcerations. So how does neuropathy happen? In short, the nerves become highly dysfunctional in and of themselves because of hyperglycemia, so too much sugar floating around. Some of the sugar goes down a metabolic pathway called the sorbitol pathway, and then you get excessive amounts of sorbitol in the tissues, which is toxic in and of itself, but a lot of that sorbitol is then converted to fructose, which is extremely toxic to tissues. Fructose and hyperglycemia lead to the formation of what are called advanced glycation end products, and these are abnormal proteins that glom onto the connective tissues and make everything very stiff, makes the mitochondria not work well, increases your levels of inflammation and oxidative stress. And sadly, neuropathy is going to affect 30 to 50% of diabetics at some point over time, and probably 100% if you consider early and low-grade neuropathy. Autonomic neuropathy is the sympathetic system, so the system of nerves that you never think about. And then you'll get altered sweating, you'll form calluses, you'll get cracked skin. These are people that have GI issues like gastroparesis. That's a form of autonomic neuropathy, and we're going to talk about that briefly too. All this needs to be looked for, but the fundamental underlying problem is too much sugar in the blood, insulin resistance, this sorbitol pathway, and then the resultant inflammation and oxidative stress that damages the nerves. We have a question.
What about taking berberine for a diabetic that takes metformin and
Glipizide? Somebody's asking if they're taking prescription metformin and glipizide for diabetes, would they or should they add berberine? I've had patients do that successfully. I would just say check with your physician, because you may be so well managed or tightly managed that if you add another method of dropping your blood glucose, it may go too low. But I have had patients use berberine in conjunction with their prescription meds. I would just check with whoever's treating you, and or if you have a continuous glucose monitor or some way to check your glucose, just test yourself, in a safe environment with somebody around in case you do become hypoglycemic a bit, okay? Berberine is a very effective, natural, all natural medicine derived from some bark of certain different plants that is a direct mimicker of metformin. So it's essentially metformin, but in a natural form, in the way that it behaves in the body. So a lot of people that are unable to get metformin will take berberine because it's cheaper, it's all natural, and it's available over the counter.
Thanks, Missy, for sharing. And meanwhile, we can share the talk.
Oh, thank you, Missy, for sharing the talk. And please do share this with anybody you know that is diabetic, pre-diabetic, or God forbid has a diabetic foot wound. So remember I told you we're going to talk about autonomic neuropathy. This image, if you can see it, depicts all of the organs that are affected by autonomic neuropathy. So remember, your nerves are touching every single part of you. You just aren't aware of a lot of it, right? We're aware of some of our nerves, the somatic system, but not the autonomic system. So autonomic neuropathy is missed all the time, a lot of times because patients aren't going to tell you the symptoms unless you ask and know to ask for them. So I ask them about sweating. We ask about erectile dysfunction, arrhythmias, orthostatic hypotension, constipation, gastroparesis, nausea, diarrhea, neurogenic bladders, and then secretomotor dysfunction, which is altered sweating as well. All of these things are signs of neuropathy that is either there or about to be there. So just if you have any of these symptoms and you're diabetic, you may want to start thinking about getting a workup for neuropathy. All right, so again, what is neuropathy? Just think of it as nerve damage at the cellular level, and then the electrical system is just kaplooey. It doesn't work right, okay? Sometimes it's because there's poor blood flow to the nerve because of the peripheral arterial disease associated with diabetes that we talked about. Sometimes it's the increased sorbitol and the toxicity that damages the flow and damages the myelin and slows down the conduction. Sometimes it's the intraneural or inside the nerve accumulation of these advanced glycation end products, or these abnormal proteins that form in the setting of too much sugar in the blood. And then what happens is you'll get balance problems, so you're a fall risk. And then people become depressed. Sometimes they get pain, and then they have all of those autonomic symptoms we talked about that nobody can really figure out or explain to them. And all of this just, it adds on each other. And I've seen patients just get so upset and miserable because A, they don't have an answer, they don't understand the connection of all of it, and nobody's really managing it properly for them. So if you have any of these things, you're feeling moody, you're a little bit down, you have pain, you've got balance problems, you notice you're very stiff, you notice you can't even bend over and touch your toe, you can't even like bring your foot up to cross your leg to tie your shoes. All of these things are showing you that you may be having dysfunctional connective tissues and things like advanced glycation end products, oxidative stress, chronic inflammation. All of it's treatable, it just needs to be recognized. Okay, somebody just asked the question, is it possible to get neuropathy after hernia surgery? I don't know how to answer that because I don't know if they mean peripheral neuropathy in the feet and the hands and they just happen to have hernia surgery. So yeah, neuropathy can happen at any point to anyone, or is this a specific nerve related to the hernia surgery? I'm not sure. Maybe ask that a little bit more targeted. Okay, next. Atrophied? Okay, so it sounds like somebody had hernia surgery and then developed neuropathy in their right leg afterwards. Yeah, so one of the number one causes, in one of my other talks, we went into this. One of the number one causes of entrapment neuropathies after surgery is positioning. So, yes, you can get neuropathic findings after surgery depending on your positioning, the padding in the surgery, and then like how long you were out for the surgery. All right, so speaking of nerves, I do a lot of nerve decompression surgeries if I think somebody has peripheral neuropathy on top of an entrapment, in a goal being to make the nerve as functional as possible and as healthy as possible. So we improve a lot of things like motor neuropathies with subclinical weakness. We improve some sensations. We definitely can improve pain with this. So don't forget that if you have diabetic neuropathy, if there's some radiating pain, shooting pain, the bottom of your foot's burning, the top of your foot's burning, your foot is achy, you feel like there's stuff in your shoes even when there's not stuff in your shoes, you can't wait to get your shoes off, leg cramping, restless leg, all these are signs of neuropathy, and there may be an associated conduction block with an entrapment neuropathy, and sometimes surgery is the answer. We try to treat people with physical therapy, like I said, the ALA infusions, like I said, different supplements, but if they don't get better quick enough, then we do nerve surgery releases like this. That is the nerve on the outside of the knee, one of the most commonly trapped up compressed nerves, and also one of the most missed problems in the medical world. So different fibers are affected with neuropathy. So there's large fiber, small fiber. Small fiber nerves are able to detect thermal, mechanical, and pain. So like pressure, pain, temperature. Large fiber is more like vibration and position. And so if you have injury to the small fibers, you're going to get burning, tingling, numbness, all the stuff you think of with peripheral neuropathy, excessive pain when there shouldn't be pain, things like that. And then injury to the large fibers, you're going to have balance problems, true numbness, you're going to get weakness, and you'll start to get that atrophy. And then some people sadly get both, a small fiber and a large fiber neuropathy combined. So the results of nerve surgery for ulceration are very, very good, and they're excellent for pain relief. And there are other modalities you can do. If you're not a great surgical candidate for surgery like this, we're releasing the tibial nerve in the ankle, which goes to the bottom of the foot. We can do things like peripheral nerve stimulators, which is a minimally invasive, highly effective way to treat nerve pain. But I like to incorporate peripheral nerve surgery into my treatment of diabetics with peripheral neuropathy and diabetic foot wounds if it's necessary, because it dramatically improves the wound healing rates and shortens the time, and people have less pain and less dysfunction, and they're generally happier. So your surgeon or whoever is taking care of your feet and your diabetic foot wounds should be able to do all of this: peripheral nerve surgery, orthoplastics, electromyographic testing, physical therapy, etc., and also have a deep understanding of diabetes and be able to work with your primary care doctor. And then I think physical therapy is critical to good outcomes in people with diabetes and people with diabetic foot ulcers. So how do we diagnose the peripheral neuropathy? Well, often we'll use an electromyographic or EMG nerve conduction study. Now, there are little filaments. You can test sensation on the bottom of the foot in different little clinical ways to do it. But I like to do this because it will rule in or rule out a nerve compression in the spine for me. It'll rule in or rule out an entrapment or compression neuropathy like I talked about. And it'll tell me if there's a primary muscle problem or a primary nerve problem. And it'll tell me if there's a true sensory motor neuropathy. So these things give us a lot of information. And what I look for is a diminished waveform. There's different little technical things to look for in these, and you need to be able to work closely with the person that's doing the study for you, which we are able to do that. But remember, a nerve conduction study is going to be normal in up to 40% of people early in the disease. It's just not going to be picked up. And if you have just small fiber neuropathy, it's never going to be picked up by one of these studies. So you have to know when to look for that and when to incorporate a skin biopsy. So you have to have a good study. You got to be able to interpret it, which we can. And then other things we do is blood work to look for fundamental underlying causes. Like, what if somebody just has a simple deficiency of B12? Well, that's easy peasy to fix, right? You just give them an IV infusion of B12 periodically, or injections, or a supplement, and then they're better. What if their A1C is double digits or worse? Well, then you know you got to get that under control. What if they have a spike in their serum protein? We got to get that under control. What if they have low protein? Well, you know, their nutrition status is depleted. So we look at all of these to try to find the fundamental reason that somebody might have this neuropathy. And we try to address those reasons while we also address the symptoms. So peripheral arterial disease, just so you know, the strongest risk factors to get peripheral arterial disease, which is when your vessels compress down so much that you're not even getting oxygenated blood to the tissues, diabetes and smoking. And if you're diabetic and you smoke, your risk is obviously amplified. So both of these are preventable, modifiable risk factors, okay? I've got plenty of patients that smoke or did smoke, and I'll offer whatever I can to get them to quit smoking, from Chantix to Wellbutrin. Some people even respond well to hypnosis. Naltrexone low dose to reduce cravings. So there's different ways to address that. And then of course the diabetes should be managed no matter what. But when you get peripheral arterial disease, then you get this image. The x-ray is showing you Charcot arthropathy, which is neuroarthropathy. So that is when you have a complete breakdown of all neural input to the bones and the connective tissues of the foot, and you get these microfractures that propagate and dislocations, and then you get these deformities. And these are the people with the so-called rocker bottom foot, or their foot is huge, or it's skewed out to the outside. This is a huge problem in the diabetic population. We are experts in the care of Charcot arthropathy and probably do some of the most limb salvage surgery in the Southeast region for this problem. I don't like seeing it when it comes into my clinic, but I certainly know how to manage it. But my real goal is to prevent it. And that's why I'm hoping you'll pick up some tricks to prevent it. If you look at this x-ray, this is something I see often. The radiologists never really comment on this when they see it. When I see this, I send people to a vascular surgeon almost immediately. And I'll also oftentimes order a scanning CT scan of the heart to look for coronary artery calcifications. I don't know if you can see it. The picture may be too small on yours, but this is an image we got of somebody's x-ray, and you can see in the back and the front these faint little gray lines. Well, what you're looking at is calcifications of the dorsalis pedis artery and the posterior tibial artery, okay? And then what that tells me is they probably have peripheral arterial disease. So if I was gonna operate on this person, I would either send them to a vascular surgeon to be evaluated, or I would get what's called a CT angiogram, which is a CT scan that can show me if the small vessels are patent into the foot, so I know if they're gonna heal a surgery. This sometimes is just calcium that deposits in the intimal layer of the vessel and doesn't really block flow. And that's great if that's the case, but I want reassurance. So I'd rather the vascular surgeon say, oh, they're fine, they can have surgery, I don't need to do anything. But what if, God forbid, he does need to do something and needs to put a stent in or blow the artery up, like with a roto-rooter or whatever procedure. So it's important that your surgeon, or whoever's taking care of your x-rays, and then how to manage it. Okay, so infection. This is going to be in 1 of 6, at least, of your diabetic foot ulcers, okay? If you get infected, that is when things really go south, obviously. The normal healing process is very stepwise. You have acute inflammation, which is normal and good. You get cell proliferation, or more and more cells form that help with the healing and the remodeling. You get migration of different macrophages and white blood cells in to take out the debris and to bring in goodness. You get angiogenesis, or formation of new blood cells. You get matrix deposition. Remember, I told you about the importance of the extracellular membrane, so important to everything. And then you get remodeling of tissue. That's normal. Well, unfortunately, in diabetes, none of that really happens in a normal way, and it's not coordinated, and things are just completely dysfunctional, particularly macrophages. So macrophages are the white blood cells that come in and chew up bad stuff, take it out, but they also signal to the rest of the body, what do we need to fix this area? In diabetes, the macrophages are converted to a type that's mostly chronically inflamed. So it's this constant chronic inflammation cycle. One of the advanced care wound products that we use for this is an amniotic type tissue, and you put it on these wounds and it converts these chronically inflamed, damaging macrophage phenotypes or types of cells to the better cells that promote more natural healing. And that affects directly the extracellular matrix and the immune process. So all of this needs to be thought about, and obviously the infection needs to be treated with the appropriate antibiotics, appropriate surgical debridement and offloading, things like that. sugar control, of course. So if you have a diabetic foot ulcer, you have dysregulated immune cells or immunity. Your immune system's kaplooey. You knew that. You have tissue necrosis or death. You get hyperproliferative callus. So you get these big buildups of callus and big toenails, and things are healing and growing abundantly everywhere that you don't need it, right? So it's dysfunctional tissue growth. You get excessive inflammation and excessive chronic low-grade inflammation. You get what are called matrix metalloproteinases. These are enzymes that come in and chew up good stuff. So this is what damages cartilage in arthritis, what damages tendons and tendonitis, things like that. You get more of these in a diabetic wound. And then, of course, there's a hypoxic environment because there's less oxygen, because there's less blood flow. And then there's delays in growing new blood cells because there's less angiogenesis. All of this contributes to the lack of the ability of a diabetic to heal a wound, which is where we come in. So the wound healing time is strongly dependent on whether it's infected, and if it is infected, how much is it infected? This is just a basic staging of ulcer, kind of a graph here that's used for like documentation and notes and stuff. It's really not relevant to you on a day-to-day basis. Up to half of diabetic foot ulcers are infected or at least colonized, like there's a bunch of bacteria sitting on them. Maybe there's no true active infection going on. And this is highly correlated with the amputation, which, as we talked about before, is highly correlated with death rates. So you could have a contaminated wound, then it becomes colonized, and it becomes deeply infected. So we want to catch it at the contaminated point and then manage it then, obviously. This is when you have dry, cracked skin, when your sugars are super duper high, so you've got too much of that sorbitol and fructose at the wound level, when you have tissue ischemia. We look for all of this to try to keep any bacteria that might want to think about making a house inside of a wound. We try to kick them out and evict them immediately. And we have different methods to do that. This is showing you one great tool. It's not convenient. A lot of patients obviously don't like this, but this is a very classic technique to treat infected bone and infected ulcers. I put a lot of frames like this on people for highly deformed, highly infected, massive ulcerations or deformity like we talked about. It's called an Ilizarov or a multi-plane ring external fixation device. These things are great because you can actually put weight on them. If you can put little foot plates on them and they support a limb and let somebody walk while they're healing an infected bone or ulcer. So that's kind of a last resort, but it's another treatment method. So even if you have osteomyelitis or infected bone with an infected ulcer, that still doesn't mean you have to have an amputation. There are ways to handle it. That's what I want you to understand. So the technical definition of infection, or how you should think about it: swelling, redness, tenderness and pain. Is the foot warm? Is there purulent pus coming from any wounds or any areas? And then there has to be an absence of any other reason for your foot to be warm and swollen. So unfortunately, people with Charcot, that neuroarthropathy problem I told you about, their foot might look just like an infected foot, and they certainly look identical on MRI. So you have to know how to tell the difference. And there are certain types of bone scans we can do, or biopsies, things like that. I know how to do all of that. We do it all the time. And in my clinic, we do, because you don't want to treat somebody with Charcot that's not infected like somebody that's infected. It's two different treatment paths. And then, of course, if you get positive cultures, and when I say positive cultures, I mean surgical cultures in a sterile environment from deep tissue, because everyone that is getting a culture in a clinic is getting a contaminated culture that's always going to have some type of positive result. Then it's going to be treated. Then we have things like antibiotic resistance develop. So if you're going to get a culture, I highly suggest you go to a surgeon that knows what they're doing, and they do it in a sterile setting from a deep tissue that is not contaminated. So again, deficient immune system, we talked about that. Wound debridement, the reason in theory that you keep having to go to the wound clinic week after week after week after week after week after week is because they're debulking the bacteria on the surface of the wound and the devitalized tissue. So in the absence of an immune system that can destroy the bacteria and get rid of it itself, you have to go in with a scalpel and forceps and remove all that bacteria. So that's one of the reasons we do wound debridements, is to replace an abnormal immune system with some mechanical debridement. It debulks the level of pathogens. And then the microbes in the wound will actually change the acid-base balance of your tissue and then produce metabolic byproducts like little proteins and stuff that affect healing even more. So diabetic foot wounds that are infected are a serious problem. So the infection must be managed. Typically, I think the best way is obviously antibiotics, but also surgically removing any actually infected tissue and then offloading it. And then, God forbid, things like that frame we talked about. So why can't these things heal? In a normal cell, you have what's called a pattern recognition receptor. So there's receptors on the surface of all of these white blood cells. Bacteria, pathogens, viruses, things like that send out little proteins and little signals that your cells recognize to be not yourself and likely from a pathogen. Okay, that's the pattern recognition receptor. And then you have the pathogen signal. So the PAMP, this is from a pathogen. Okay, it's an antigen from a pathogen. That is the little signal that attaches to the pattern recognition receptor. And then that goes into the cell. There's a transcription factor that goes to the gene, okay? And then the cell starts making proteins that help heal and fight off the pathogen. Well, in diabetes, the pattern recognition receptor is defective, doesn't recognize the badness, and doesn't behave normally. That's one of the sources of immune dysfunction. And you have to recognize that and be able to manage it accordingly. So one thing that we do in my clinic, we actually have a PCR machine just for this purpose, to get a molecular DNA level diagnosis of all pathogens that are affecting a diabetic wound or an infected toenail, which can sometimes lead to problems with wounds, okay? So culture-based identification has been shown to be inadequate over the years that we've been doing it. Can only identify a very small number of the pathogens and invaders, and it's only going to be the ones that you are actively looking for. It's not going to recognize everything. And this has led to our incorrect belief in the medical community that there's really only 3 bugs that are responsible for all of these problems, namely Staph aureus, Streptococcus, and P. aeruginosa. These new molecular PCR-based techniques, which really came of age in COVID, of course, gives us a very precise DNA-based diagnosis of every bug that is affecting your wound or nails. So I use this when possible. It's not always covered. The insurance companies don't want us using it all the time, of course. But if it's allowed and if it's medically indicated, I think this is a great tool to help us direct the treatment with the actual appropriate antibiotic and where we're not just guessing. So what do you do? How do you prevent? How do you treat these things? This is a total contact cast being put on something. This is a very classic time-honored treatment that I still do today. If it's indicated, I know how to put on a total contact cast. My team does too. What this type of cast does is completely distributes all forces in the foot equally and protects soft tissue at the same time. So it's a way to sort of modify contact pressures if you have an area of ulceration, okay? Again, we manage the neuropathy. We treat the neuropathy if we can, or we surgically treat the neuropathy. Peripheral vascular disease, we look for it, identify it, treat it, okay? Infection, obviously, we look for this. We prevent it if possible. We try to identify the right antibiotic and use that. We treat it. And again, I think molecular diagnostics are best. And then contact pressures. This is where surgery comes in for diabetic foot ulcers. Anytime you have a deformed foot, tight tendon, an area of elevated contact pressures that are leading to this ulcer in the setting of neuropathy and ischemia, if you can reduce the pressure on that wound, it will have a much better chance of healing more quickly. So I see a lot of patients that have been in wound care clinics for years, unfortunately, and they have a clear deformity, and the wound at that deformity is just continually debrided week after week after week after week. Very expensive wound care products are put on it again and again and again. It heals up. They come out of the contact cast after they've had their debridements for a while, and guess what? The ulcer comes back. Remember I told you 80% recur? When I see these patients, I try to identify what is causing that abnormal contact pressure, and I will surgically fix it. And sometimes that is what is required. As you know, if you followed me at all, you know I try to avoid surgery at all costs. But in these cases, sometimes surgery is the most conservative treatment plan. And so that's what I do. So your wound care journey does not have to be the doom spiral that it currently is. Remember, the wound care business model is repeated debridements and product markups, okay? So I want to get you out of that doom spiral. This image is showing you the planning of an adipofascial cutaneous skin turn down flap based off of a pedicle. What do I mean? Well, all the arteries in your leg have certain branch points where they feed the skin and the muscle and the fascia around them. Those are called perforators. So if you can identify a certain perforator, you can build a rotation flap around that, move that vascularized normal tissue to where it's not normal, get that ulcer to heal, and then you can just skin graft or close where you took the donor tissue, okay? This is a highly effective method. It does not require a free flap. Some wounds do require free flaps, but this is just moving tissue around in a very precise and elegant way. I do this in my clinic for people, not in my clinic, in the surgery center, obviously, but we are able to offer this. So remember, a lot of your wound care clinics don't have this capability. They don't even know to think about this. So I just want you to know that this is a possibility. And if you have one of these wounds, it's just not getting better, not getting better, not getting better, you may want to go find someone that is trained and able to do orthoplastics techniques like we can at Warner Orthopedics. Your current average wound healing time in America is anywhere from 106 to 229 days. That's horrible. So you basically, your whole year is going to be spent on this wound that has an 80% chance of recurring. To me, that's terrible numbers, and I really try to diminish that. We have been able to shorten that time dramatically and prevent recurrence rates a lot with all of these other techniques I've brought in. So typically you would have weekly or bi-weekly visits to your wound care clinic. They would debride it, they'd put some salves on, they'd put some dressings. Sometimes you go to hyperbaric oxygen therapy, which I think hyperbaric oxygen therapy is a great tool, but the problem is the protocols are very inconvenient. So you have to go every day for 90 minutes for like 6 weeks, which is miserable. But it is effective. But if there's a way to bring oxygenated tissue with a simple rotation flap, wouldn't that be easier? I think so, yes. These things take months and months to heal. And then, of course, the ulcers recur. 25% won't heal at all, even with quote unquote optimal conditions under standard care. So again, surgical offloading with tendon rebalancing, we do that. So like, let's say you have an ulcer on the plantar aspect or the ball of your foot, okay? One simple trick that can be done is to lengthen the Achilles tendon complex, and that can be done surgically very quickly with no downtime. And that alone takes pressure off of the ball of the foot and can reduce the healing time of a diabetic foot ulcer there. That's the simplest example I can give you. So thinking about surgical offloading with either removing bony bumps, tendon rebalancing, the orthoplastics approach like we've talked about with rotation flaps, pedicle flaps, perforator flaps, even simple things like skin grafting. And then applying external fixation to offload the foot completely, as we discussed in that previous slide, as indicated. All of these things should be in your toolbox if you're treating diabetes and diabetic foot wounds. They are in my toolbox for you. And I'm not going to do these surgeries unless I know for sure they're going to help you. So here's a post-traumatic wound that's at the ankle. That's at the inner ankle bone, okay? And this person had a bone infection. They had failed an ankle fusion. So what I did, when my partner at LSU asked me for help, I came in, we debrided the wound, we put in that white ball in between the long bone of the tibia and the foot bones, the talus. That is called bioglass. That is a very new synthetic material that's actually from a Finnish company that I use. It is a bone graft, so it'll become bone over time, but the beauty of it is it's naturally antimicrobial for all pathogens. So I put it in there to help treat the infection, and then we did a rotation flap to cover that wound with a skin graft, and it all healed up fine. And this guy had been dealing with this wound for probably 6 months prior to this procedure. So we had complete healing of the wound and the bone in 2.5 months with the adipofascial turn down flap and the bioglass. I will tell you there was a frame. We did put him in a frame for a short term, but he was able to walk on it. So it wasn't that debilitating to his day-to-day life. And this is just showing you that turn down flap. And then the image on the far right, I have a little thermal infrared camera I can use intraoperatively and in my clinic that'll tell me if an area is getting appropriate blood flow. So it's pretty cool. It's like a heat map of the limb. So I can see what the temperature is at any given point using this little camera device I have. So I was able to measure and show that, yes, this little turn down flap I had was getting flow from that perforator. So it was going to live, it was going to make it. So we just flipped down the tissue to cover that medial ankle wound and then ended up closing where we took it from and put some skin graft on. And that was it. Put him in the frame with the bioglass. He was able to walk on it and again healed in 2.5 months, where he had been dealing with this after his fracture and his infected ankle bone for at least 6 months prior to that. Tendon rebalancing, super duper important. Everybody forgets about it, overlooked by most foot doctors. So you can have in the top right, it's just showing you a heel that's too tight on one side. It's not that nice neutral position where you have normal weight bearing on the fat pad of the heel like you're supposed to. If your posterior tibial tendon's too tight, you're going to walk on the outside of your foot. If your peroneal tendons are too tight, you're going to walk on the inside of your foot. And you'll get ulcers on different parts of your foot, depending on which tendons are too tight, which tendons are too loose. You have to have a deep understanding of the mechanical properties of the foot and ankle, and also the anatomy to be able to understand this and then to be able to address it surgically or with physical therapy, ideally. So again, this is overlooked by many foot doctors and wound clinics, but at Warner Orthopedics, where we are dedicated to all of this, we do not overlook this. If there's a simple tendon rebalancing procedure that can be done to save your leg, we're going to do it. So this shows you that rocker bottom foot. So that's going to be a tight tibialis anterior tendon, a tight gastrocsoleus, and may or may not include a tight inside or outside tendon, okay? So this image on the right is showing you just a simple little procedure to release the heel cord by snipping a part of one of the muscles that goes to the heel cord of the Achilles tendon, okay? We snip the little tendon, it lets the muscle relax, and it basically, I think of it like taking the place of 4 or 5 months of physical therapy to try to stretch that out. So it's a very, very effective way to offload surgically these areas of high contact pressure. So this person, I don't know if you can see it on the left, that's looking at the bottom of the foot of this person that came to me. And obviously they've had prior amputations, right? And the number one risk of having a future amputation is having had a prior amputation, just like the number one risk of getting neck pain or back pain is having had pain before. So this person who's clearly has a foot at risk, and you can see the foot's kind of torqued over and it was tight in the heel cord, and they had an ulcer on the side of the foot. Once the ulcer finally healed so that we could take him to surgery and not worry about infection, we just lengthened the Achilles tendon a little bit and lengthened the posterior tibial tendon on the inside, and his foot is nice and balanced now, and he's got a nice, what we call plantigrade foot flat position on the ground, and he's no longer like this, so that ulcer is not going to recur. Very simple procedure. Weight bearing is tolerated immediately. We put him in a boot. He's just going to walk tomorrow or the next day. It's something that should always be thought about and certainly should not be overlooked. What are your predictors of healing a diabetic foot ulcer or a diabetic foot wound? Well, if you're a non-smoker, you have a better chance than if you're a smoker. If you have limited peripheral vascular disease, you have a better chance than if you have peripheral vascular disease. We look for wound improvement by at least 40% within a month because that's your best sign. So if you show improvement, you can count on future improvement, right? It makes sense. If you don't show improvement, you should change your tactics. And we are very, very dedicated to following improvement with measurements, tissue depth, temperature gauges like I told you about, cultures, etc. Good glycemic control is hugely important. You know that, I know that, everybody knows that. It's just hard to do. And then you need to have good doctors. You need to have somebody that's able to do more than just debride or slap on some wound care products. You need to have somebody that has an understanding of the diabetes, the fundamental problems of chronic inflammation, the fundamental problems of oxidative stress and advanced glycation end products, somebody that understands nutrition, somebody that understands supplements, and then somebody that understands anatomy and surgery and is able to do these things, and also neuropathy. And then I just can't emphasize good nutrition enough. So there are some newer technologies coming out you may or may not have heard of. Topical oxygen delivery. Remember I told you about hyperbaric oxygens and how inconvenient it is? Well, the tanks that you go in for these treatments are also massively expensive and require a subspecialty type of a physician to manage it while you're in there, so it becomes a very expensive endeavor. Well, now there's newer ways to apply oxygen topically at a location where you need it. There are things called sodium octasulfate dressing, so a new specialized dressing to try to change that environment in a wound that is preventing healing. Placental-derived wound care products, so amniotic tissue-based things, these things are awesome. If you get a connective tissue matrix from amniotic tissue, you can actually improve the extracellular matrix of any connective tissue dramatically and improve it for the better. In the wound care world, you use amniotic tissue. Sometimes you lay it on the tissue, sometimes you inject it, sometimes you wrap it around things. We've been wrapping amniotic tissue around nerves and nerve surgery, gosh, for over 10, 15 years to reduce adhesions and help healing. So placental-derived wound care products are an important adjunct to this, but should not be the only thing that you use. Targeted antibiotics, can't emphasize it enough, or targeted antifungals. Molecular diagnostics are the best, I think. Things like platelet-rich plasma, that's when we draw your blood, we centrifuge it, and again, we can do this in my clinic. You separate the red cells out from the white cells, so you have concentrated platelets, which are the little structures that hold all the proteins and growth factors for healing. And then you just put that right on the wound or inject it around the wound. And that's been shown to dramatically reduce wound healing times. And then, of course, deformity correction. You have to offload it. You can't have an ulcer with a high contact pressure, treat the ulcer and leave the high contact pressure. That makes absolutely no sense, but that is the standard of care right now at most wound centers. And then Charcot and neuropathy. We talked about this. The x-ray on the top is showing you sort of semi-normal foot architecture, and then the x-ray on the bottom is showing you that the arch has just gone boop. That's when you get that rocker bottom foot. That's when you get a plantar ulceration, a tight heel cord, et cetera, et cetera. So Charcot is when you have breakdown of the bone, deformation of the foot structure itself, increased areas of contact pressure, tight contracted tissues, and the inability to heal minor trauma. And then the trauma just causes more trauma, which causes more trauma, which eventually causes all of the foot bones to fracture and dislocate, and it's just a disaster. This is not a peripheral arterial disease problem. In fact, these patients usually have a ton of blood flow. In fact, it's hypervascular, and it is extremely easily missed initially. I can't tell you how many diabetic patients with a deformed foot I've seen where they had a simple little sprain, they stepped off a curve wrong, and everyone just treated it like it was nothing, nothing's wrong. Oh, you just have an ankle sprain, don't worry about it. If you have a diabetic with neuropathy and you have any type of minor trauma, you need to go see someone that understands Charcot arthropathy, because it needs to be immobilized and managed immediately to prevent the breakdown from happening. And it is extremely easy to miss. It's missed all the time, and I don't want that to happen to you. So you need to have very patient-specific, precise, and timely treatment. The connective tissues are dramatically affected in this condition, and bone being one of them. And it's usually in people with neuropathy. So as originally described, Charcot arthropathy or neuroarthropathy was originally described in the population with tertiary syphilis. And then Jean-Martin Charcot and Charles Ferret were the first to describe it, and then an Englishman, Page, also described it. So we've been treating this for forever and ever and ever and ever. And it usually presents as a painless, right? Because remember, it's neuropathic people. They don't have normal sensation, but the foot's swollen for no apparent reason, and oftentimes it's warm. So if you stepped off a curb and you notice you have a swollen foot, it doesn't really hurt, I would go get it checked out, because you probably may have the early stages of Charcot, and that's when you want to catch it and treat it, and then it doesn't get worse. Most patients sadly don't have any recollection of the traumatic event. They just notice, oh, I can't seem to fit in my shoe, and that's when they go see treatment. Don't wait that long. Make sure you check your feet every day. And if you notice any kind of swelling, what I tell my patients to do, believe it or not, is to go get an infrared temperature gauge, like the ones you use now to check the temperature for fever and things like that. I just tell them to get it at Home Depot. Now, obviously, that's not medical grade, and I'm not making treatment recommendations. Talk to your physician. But if you have one of these infrared temperature gauges and you notice that one foot is 5 degrees hotter than the other one, you're definitely on the wrong path and need to go get that checked out. All right, so minor trauma in the setting of neuropathy leads to active Charcot. We talked about that. Hot, swollen red foot, sounds like infection, right? Remember I told you it's very similar. So you need to go see someone that knows the difference. The swelling will go down when you elevate in Charcot. It won't go down with elevation and infection. The initial stage in the progression, if you catch it in the initial stage when the inflammation is just starting, you can resolve it with immobilization, anti-inflammatories, different bone type medications, and then the IV infusions like we talked about in different supplements. Contact casting is very helpful, and then the Charcot restraint orthotic walker. It's a specialized, custom, removable cast. I think of it that way. We make them for people in our clinic. That's another effective way to offload and manage this early. But if you don't, then you'll get a deformity, which then can lead to an ulcer, which then can lead to an amputation. So it's important to recognize this problem. That is a rocker bottom deformity and showing you sort of an x-ray to coincide with it. You can imagine if you're stepping on that foot with that point pressure, you're at risk of an ulceration at the apex of that arc, right? That's what we're trying to avoid. That's when you need the offloading, either with diabetic inserts in shoes or surgical offloading. To reduce those bony contact pressures. And then this is when tendon rebalancing comes into play. And you want to get into a foot that's plantigrade, where you're a tripod again, hopefully, heel first, fifth toe, right, where you're supposed to be bearing weight, and or you're able to get into a brace to keep it in that position. Those are our goals. And then, of course, if you end up with Charcot arthropathy and you have a massive deformity, we have ways to fix that. We are experts in the care of Charcot arthropathy. We do more Charcot surgeries than anyone in the region. Everything from tendon rebalancing to Ilizarov frames to deformity correction to big fusions. So it is fixable, even if you're at the worst stages. I just, in a perfect world, would never want you to get where you need that surgery.
Can Charcot Foot be inherited?
The question is, can Charcot foot be inherited? In the same way that insulin resistance and diabetes are heritable, yes. But we're finding that what we used to think of as hereditary problems is really just everybody's living the same lifestyle, right? You're in the same house, you're eating the same foods, you're around the same environmental toxins, drinking the same water, have the same stress levels. So a lot of these problems like diabetes and insulin resistance are from inflammation and oxidative stress, which directly leads to nutrition and hyperglycemia. So yeah, it's heritable, but nobody's found a gene for this yet, if that's what you're asking. So these are the things we look for. We try to isolate each one, the what's in the wound, where is the wound, why is the wound there, what's the contact pressure, what's the depth of wound, what's the measurement, et cetera, et cetera. Is there or is there not an infection? Is there or is there not peripheral vascular disease? What is a neuropathy picture? What is a hyperglycemia picture? Everything needs to be looked at if you want to heal an ulcer and you don't want it to recur. So we assess and treat peripheral vascular disease and infection. We assess and treat neuropathy. We offload non-surgically if possible, surgical if we have to. We do wound care, obviously. We will surgically offload. We will do surgical wound correction with orthoplastics and internal or external fixation. And if, God forbid, you're at the stage of Charcot, we can correct those deformities. This is another image of a perforator flap to heal one of the worst places you can get a wound, which is on your Achilles tendon. And this is just based off of one of the perineal artery perforators. Just turn down that flap, cover it up, save this person probably a year in wound care. Okay, you may be wondering, what supplements, what are you talking about? Alpha lipoic acid is probably my favorite. This is a natural substance that is antioxidant to both fatty tissue and water-based tissue. So most antioxidants in the body are one or the other, like vitamin E is for fat, vitamin C is for water-based tissue. Alpha lipoic acid can go both ways. And so it's great for the myelin sheath, which is fatty for nerves, and also for the cytosol of the nerve cells themselves. So alpha lipoic acid is used in Europe as one of the first tier or primary ways to treat diabetic neuropathy and neuropathic pain. We offer it in both an oral supplement form through the Well Theory, which is my line of natural supplements, but we also have a way to give it to people with IV therapy. So we'll do a series of IV treatments of 600 milligram with or without B12, depending on what their needs are. And it's been dramatically helpful for patients with nerve pain, even things like residual sciatica, failed back syndrome. Think of any reason that a nerve might hurt, not just diabetic peripheral neuropathy, but alpha lipoic acid is great. Palmitoyl ethanolamide, this is a fatty acid amide. It's in the same family as cannabinoids, right? So it's in the endocannabinoid family. This thing, PEA, dramatically helps your brain, but also treats nerve pain. Why? Because it prevents the inflammatory response around the peripheral nerve endings in the setting of chronic inflammation and oxidative stress, which is what we're talking about. So the combination of ALA and PEA, it's very powerful for neuropathic pain. I also like omega-3 fatty acids because that just makes you naturally anti-inflammatory. And of course, D3 is massively important. So for neuropathy, we talked about it, ALA, PEA, the B vitamins, D3, omega-3s. That combination is very, very powerful to assist your nerves to get better on their own if it's at all possible. Now, for wound healing, one of the things that you need that is often forgotten is protein. One of the markers we look at in serum is levels of albumin, which is a type of protein. And if you have low levels of albumin or pre-albumin or low levels of lymphocytes, these are markers of malnutrition. So protein, you have to have protein, the amino acids in the protein that are used to rebuild the collagen, the connective tissue, and the extracellular matrix. We've been talking about this entire talk. So you have to have enough good protein intake for proper connective tissue healing. You've got to give yourself the collagen backbone. This ends up being about 3.52 ounces for every 150 pounds for a male. So it's not a ton of protein. This is just the replacement, like what you would lose on a normal daily basis. So you probably want a little bit more to heal a wound. But just don't forget protein. If you're going to eat meat, animal products, try to make sure they're organic, cage-free, grass-fed, grass-finished. Stay away from anything that's been fed GMO corn or soy. And then if you can, go with the plant-based proteins. But I'm a big believer and love eggs, grass-finished red meat. Like I have no problem with healthy animal proteins in moderation, of course. But there's plenty of protein found in things like edamame, shiitake mushrooms, lentils. There's a million plant sources of protein, so don't forget those. Okay, so many of my patients that have diabetic foot ulcers, many diabetics in general, many Americans in general have micronutrient deficiencies. Most people are deficient in zinc. Most people are subclinically deficient in B12, particularly as we get older. Vitamin C, none of us are getting enough of that. D3, we're all D deficient. I cannot tell you how many people with single-digit D levels I find every day in clinic. It's horrible. So I'm a big fan of checking vitamin D. I know that the insurance companies aren't big fans of that, but I pick up D deficiency all the time. We treat it, and guess what? People feel a lot better. They get sick less often. They're able to heal things quicker. Calcium, magnesium, 60% of Americans are mag deficient. Magnesium plays directly into how your muscles and your nerves function. And then, of course, we're all deficient in antioxidants and anti-inflammatories that are natural. I look for all of these, and then we will offer different supplements or different diet plans to try to address each of these deficiencies. And then simple things like red light therapy. So when I mention things like this around other orthopedic surgeons, they look at me like I have 4 heads and 3 eyes. But I will tell you that NASA is behind most of the research that began the ability for us to use this in medicine. In fact, it won the Nobel Prize in 1903. Red light accelerated the healing of sores. They found out accidentally, then delved into it. And that's much like most things in medicine, we find out by accident. But somebody got the Nobel Prize for this. It was ignored for a while because nobody really knew how it worked. And then NASA decided to look into it to help the astronauts up in space. They were looking at it with plant growth, like different LEDs to help with plant growth, and noticed that skin abrasions healed faster when they were around red light with the LEDs. And so then they got some small business innovation grants and some NASA grants. Research red light therapy and proved that, in fact, it does improve healing. It does reduce pain. And it does this by being absorbed by a chromophore or a light sensitive molecule in your cells, particularly cytochrome C oxidase, which is found in the mitochondria. That senses the red light. It stimulates the mitochondria to be more efficient and produce energy better. And as you know, if you've watched any of my talks, you know that mitochondria dysfunction is one of the fundamental problems. So if you can get your mitochondria producing energy properly and spewing out less reactive oxygen species and less oxidative stress, you're going to get better. The US Navy did a study and found that lacerations healed 50% faster. So I am often telling my patients, go use my infrared sauna, just go sit in it 20 minutes, 30 minutes, it's going to help you. Or I tell them to go get a red light wand. So just the simplest things can help you heal these ulcers and shorten that time that you're probably used to or you've seen people go through. Water balance and hydration is critical for the healing of any wound, surgical or otherwise. Water balance and hydration is critical for the healing of a diabetic foot ulcer. Now, you may want to combine hydration therapy or IV therapy with B12. You may want to combine it with vitamin C. You may want to combine it with D. You may want to combine it with ALA. And in fact, I've had patients with diabetic wounds or diabetic peripheral neuropathy do all of that. And then that helps get the right fluid balance in the tissues for healing. And it also gives you the micronutrients in which you're probably deficient. We can even add things like zinc if necessary. So tissue hydration is not the same as the fluid you see come out of bad wounds. That's called a wound exudate. You can still have a dehydrated tissue with a heavy wound exudate. Hydration is fundamental to blood flow, fundamental to tissue growth, tissue health. So you have to have proper hydration, and IV therapy is sometimes the best way to get that. And then you need the micronutrients too. And so IV therapy can combine both. So that's another tool that is out there for you. So just keep it in the back of your mind. So in summary, we've kind of gone over a ton. Each thing could probably be its own talk, but diabetic foot ulcers, think of the trifecta that leads to the worst ones, which is peripheral arterial disease, neuropathy, and infection. So we want to manage all of that and the hyperglycemia. Early diagnosis of neuropathy and arterial disease is key, and early management of those problems is key. Nutrition and micronutrients matter more than you think. You have to have good nutrition, and you cannot be deficient in micronutrients if you want a proper function to your immune system. Wound care, that repeated visit to the wound care clinic and to hyperbarics, can be replaced with faster, more effective methods. You just need to go somewhere where they know how to do those other methods. And then if you have a diabetic foot ulcer, remember, it can lead to amputations, which can lead to death 30% of the time. Remember the elevated morbidity at 50% at 3 years. And then just in general, having a diabetic foot ulcer just leads to a poor quality of life and depression and social isolation. We don't want that for anybody. So let's get these things healed quicker, or even better, prevent them from forming at all. So my goal, our goal at Warner Orthopedics, is to prevent your risk of diabetic foot ulcers. And then if you have one, to get it healed as quickly as possible and to prevent that risk of recurrence that is so common otherwise. Okay, we have one question. The question is, does gabapentin help with nerve pain? Yes. Gabapentin started out as an anticonvulsant, so an anti-seizure medication, and it is off-label used all of the time for nerve pain. Lyrica is another one. I try to stay away from Lyrica because its side effect is weight gain, which most people don't want. But in some cases, gabapentin is not effective even at very high doses, and so people have to convert to Lyrica. Amitriptyline is another synthetic medication that can be used for nerve pain. And then simple things like Celebrex and ibuprofen, believe it or not, sometimes are effective. I would avoid narcotics at all costs. But yes, gabapentin is a relatively safe, common method to treat nerve pain. I don't know if you guys know, but I wrote a book to try to encapsulate all of my thoughts and teachings and knowledge base on how to treat orthopedic conditions naturally. It's called Bone on Bone, and it goes through a stepwise protocol for you to help you manage all of your aches and pains, creaky joints, damaged connective tissue, arthritis, diabetic foot problems, things like that. There are ways to manage these things non-operatively, and if you need surgery, if you follow these steps, your outcomes are going to be just so much better. So it's called Bone on Bone. It's being published in May. It's available for pre-order now on Amazon. This is my nurse practitioner that I told you about at the beginning of the slide, who's extremely knowledgeable about wound care, anatomy, diabetes, neuropathy, and she and I work very closely together all the time to help take care of our patients. Lauren Broussard. Are there any more questions? Remember, if you have anybody that's diabetic, pre-diabetic, has an ulcer, you think might be at risk of an ulcer, share this with them just so they know there's options out there and what they can do to help themselves.